Martijn Arns, welcome to the
Yeah,
podcast.
well, thanks a lot for inviting me.
Look, the reason I invited you is I saw a post of yours on LinkedIn, and I dove into the post, and then I looked into your background. And as soon as I looked into your background, I'm like, this is the guy that I want to get onto my podcast, because of the research that you're doing. But you describe yourself as a biological psychologist, not a clinical psychologist. So tell our listeners the difference between those two things.
Yeah, I think there's quite a big difference. I mean, at the time when I started studying, it was like from the say 300-400 psychologist students a year. There would only be like 3 to 4, maybe a handful that would opt for studying physiological psychology or biological psychology, as we name it nowadays. And usually I tell people I don't talk to people. I just want to see their brain activity. Biological psychology is more really the biological side of psychology, where we're more interested in interrelating behavior to brain. So it's not about checking checklists or just talk therapy. I mean, although it could be part of the interest when you want to see how it works in the brain. But the primary viewpoint is coming from the brain, which is, I think, quite different from psychology, which is more clinical psychology, which is more the reverse.
Yeah, and so give our listeners a bit of a journey through your background, both in academia and then in the work that you do.
Yeah. So yeah, when I finished my study, which is, let me count, a long time ago, there was somewhere 1998, after having spent also some time in down under and at some other research places. So when I started studying, my specialty was mostly educating people to mostly get a role in pharma industry, because there was a lot of preclinical research going on where behavioral of animals was very important to inform if a drug would be an antidepressant drug or an antipsychotic drug, etc. So I've worked there for a very brief bit at that point in time as well. But over and over again, I was like, well, I want to do more translational research. I want to better understand how we can benefit from knowledge from the brain and applying that to humans directly in order to make a difference from treatment perspectives. So after I spent doing research at various research institutes, for example, I did my studies in Nijmegen, the Netherlands. Then I had a tour in Sydney, Australia, in the Westmead Hospital. I joined a group of Evian Gordon and Leanne Williams. I think she joined it later, actually.
I know Evian Gordon and Lee Williams,
Okay.
so Evian with the Brain Resource Institute. I used to work with those guys a decade ago.
Yeah, exactly.
How
Well,
funny.
exactly. I mean, that was also a little bit the way how I got started several years later, because in 97, 98, I did a project at Westmead Hospital under the supervision of Evian Gordon. They really learned about collecting EEG data in lots of people. And then I made a bit of a detour. I also went to the Max Planck Institute, which was more like memory research. And then I started a PhD in Glasgow, in Scotland, together with Organon, which was a pharma company at that time. And that all resulted in the fact of me realizing, like, well, it's all that fundamental research is too far away of where we are going. And then after a couple of years spending time in the IT, this was like beginning of the 2000s, where even a psychologist could get a job in IT and would all be offered a good salary and a car. I spent 1.5 years there because, of course, scientists traveling the world doesn't make you a lot of money. So I needed to pay back some of my debts at that time. So then Evian Gordon indeed went IPO with the Brain Resource Company and approached me back again, like if I was interested in setting up, at least in the Netherlands / the European, some of the European part of the Brain Resource Company. And that's how I got started with brain clinics in the very early days. So I made a business plan at that time, and the conclusion was like, there's no money to be made here. So I thought, well, that's a great business plan. Let's start doing it. So I jumped into it, and yeah, we started collecting some data for the Brain Resource Company. But very early on, I already realized, like, well, we have this brain scanning technique. We can compare brain scans to a database and have more objective information, and therefore realizing like this could be a very interesting jumping platform to branch out to other applications. And one of the ideas I had at that time already is, like, rather than making a diagnosis on the outside based on a behavioral checklist like rating depression, etc., we need to look under the hood to better marry a patient to their treatment or their drug of treatment, if you will. And that's been the
Yes.
primary motivation ever since. And I think we've come a long way across that journey ever since. And that's basically how I got started in starting my own private research institute at that time. On the one hand, collaborating with Brain Resource, but also getting to go with our own research lines and advancing applied neuroscience. So that's in a nutshell.
Yes, now very interesting because I actually studied in Glasgow University as well. I did a master's in nutrition at Glasgow Uni. Geez, it's a cold, wet, dour place in the middle of winter, isn't it?
Yeah, well, the funny thing is I've spent quite some time in all these places, and to be honest, Munich was my least favorite place. At least at that time as a student, it was really hard to get integrated, and Glasgow was the funniest place. Sorry, even above Sydney.
It was a lot of fun.
Exactly.
It was a
The
lot of fun,
people really
Glasgow.
go good, no matter how dark and depressing it was outside, inside at the bars, in places. They're really friendly, welcoming people. I had the greatest time in Glasgow, to be honest.
Yes, yes, me too. Ashton Lane, a bit of time in there. I'm sure you've frequented Ashton Lane once or twice. Tell me this before we dig into this. Did you ever come across Dr. Roy Sugarman in your time in the Brain Resource Company? He worked with Evie.
Yeah, I know.
Roy
I've had
pretty well.
some exchanges with him. I don't recall. I mean, this is probably like more than 20, 25 years ago that we had some latest
Yeah,
interactions.
okay.
Yeah, but the name
Yeah, very cool.
the name rings a bell for sure.
So let's talk. You mentioned something there about with psychiatric disorders, the checklist. Now, my listeners will have heard me, if they're regular listeners, say before that psychiatry is the only branch of medicine where people are diagnosed with conditions without a biological signature at all. Are we any closer to biological signatures? And if you could explain what that means to people, you'll explain it a lot better than me. And are we getting any closer to biological signatures for different psychiatric conditions? And then and how do we use the brain and the information from the brain to inform treatment? There's a few questions in there. Take them any order you want.
Well, it's going to be a long answer. Yes and no is the short answer. And the longer answer is indeed like you're suggesting. The running joke is a little bit like the psychiatrist, that's the only MD that doesn't first inspect the organ he's treating. And that's really how it is in current medicine, and especially in psychiatry. We take a checklist, we rate specific behaviors, we match it to the DSM-4, very important. It's not the set of behavioral criteria that make a diagnosis of depression or ADHD. It's the final question, and the final question is clinical impairment. So someone can have meet a list of criteria and not being able to concentrate, impulsive, etc. But in the end, if there's no clinical impairment, then the diagnosis will not be made. And remember this, because this is a very important notion, because let's visualize two people. We have one person who is a CEO in a company, very impulsive, very inattentive, probably has a PA to cover up for all that inattentive behavior, etc. But his impulsiveness, etc., is one of his core strengths. Now, let's take on the other hand this other person, a white-collar worker, say, very inattentive, impulsive, and well, his boss is not really happy with it, and therefore gets referred out to an MD or to a psychiatrist. They do the checklist, and they will note some clinical impairment because his complaints are impacting on his job, and therefore there's clinical impairment. So therefore, that person might receive a diagnosis of ADHD, of course, a bit more complicated, like I'm painting the picture right now. But the CEO, on the other hand, will not get a diagnosis. And this automatically will already tell you that a biomarker-driven psychiatry will be impossible. Because with my biomarker, I might pick up on the level of inattention, impulsivity. I could pick up on all those complaints maybe very reliably, but I will never pick up on the clinical impairment, which is more situational, environmental. And that's why, by definition, a biomarker will never work. and this is the most important reason. There's multiple other reasons of reliability that even raters could vary well in rating, and there's also environmental, societal changes where some behavior is seen more easily as deviating from the norm than it would be 10, 20 years ago. But apart from that, I think this is the most crucial reason why a biomarker can never be used for diagnosis as they are today. So we need to develop ourselves to a new framework. Now, with the other question you asked, and I think this is a way more important question, because why would we want to stick a label to someone's forehead in terms of a diagnosis? Well, according to the DSM-4, DSM-5, the only reason to have these terminologies of depression, ADHD, etc., is to foster communication among professionals. So it's only meant as a language that if you and I talk about depression, that we both understand what we're talking about. The DSM-4 and 5 was never developed to be a diagnostic framework to be used to develop treatments upon. It was never designed for insurance companies to exercise upon. That was never behind it, but still there was a whole industry that started building antipsychotics and antidepressants, etc., whereas it was never intended for that purpose. Now, it's just there to foster.
So it's been so Martin. So it's my understanding though that it's been hijacked a little bit by industry for them to develop specific treatments. Is that what you're saying?
Yeah, I mean that's one way to look at it. I mean, not maybe purposely. I mean, on the other hand, developing a drug, I'm not saying hijacked in a negative sense. I mean, if you develop a drug, you would like to cling onto something to make understandable what it is that drug is doing. So it's very understandable, but it's also, I think, has put us on a trajectory where we are currently are. That the effectiveness of most treatments are very, very low. If we look at depression, and I can paint the whole landscape from you, ranging from psychotherapy, all antidepressant medications, brain stimulation techniques, ketamine, psychedelics, etc. Overall, the response remission rates on the group level are roughly 30, 40, 45%. And when you look at the larger studies around. So if you go to the casino and you know your winning chances are that low, I'm not sure that casinos will do good business. Well, in psychiatry, that's what we have to deal with. And that's why we have this stepped care model that we keep on putting people on new drugs until we have found a treatment that will benefit a majority. And when going through 4 different steps, only 2/3 of people are actually helped. And so it's a very excruciating process knowing that you're dealing with patients that have comorbid suicidality, that are very impaired in their lives. So this is really the worst discipline, I think, from an effectiveness point of view, maybe in the whole of medicine.
And look, I think that's pretty clear from the data that the interventions in psychiatry are pretty poor compared to other branches of medicine, and unacceptable for some branches of medicine. But how is neuroscience helping?
Well, this is, I think, the topic where we have to be more optimistic, because knowing that on the group level, a treatment is only effective in 30 to 40%, and also knowing that if people that do not respond to one treatment might be responding to another treatment, that's where the real hope is. And that's really where I think we can make a difference. And consistently, throughout all the data we have collected in our lives, we've been part of the iSpot-D study. That was this large study that was funded by Evian Gordon and Brain Resource, the largest biomarker study to date. And that study has been confirming what I just said. If we make correlations between symptom profiles and baseline EEG, we never found something. But if you start making correlations between brain activity at baseline and behavior in the future, so like the symptoms in the future, we did find a significant association. So that's already telling you that your baseline, the way your brain activity is at this point in time, is predictive of the trajectory to responding to a drug. So if you're responding to a drug, you have a different type of EEG than relative to when you're not responding to a treatment. So in the first quest, we really started to asking the question, can we predict people that are responding and non-responding to treatment? And the simple answer is yes, and we can to quite some substantial degree predict it. However, when you develop
what sort of accuracy, sorry, Martin, what sort of accuracy are we talking here in terms of predictive
Yeah,
power?
that's what I wanted to get into, because it was not like in the 80, 90 or 90 plus kind of sensitivity. So we would still be on the lower end of sensitivity and specificity, and more like 60, 70%, which that's what I wanted to explain as well, which indeed is clinically very challenging, because if you cannot be absolutely accurate that someone will or will not respond, then you also cannot make a decision to prescribe or to withhold a treatment. And to prescribe a treatment can ethically be justified quite easily, but you cannot very easily tell someone like, well, my biomarker tells me you're not going to respond to this treatment with an 80% accuracy. That still means that someone has a likelihood of 20% to respond to the treatment.
20%.
And ethically,
Yes.
you cannot make that call, not until you have an
Yes.
alternative to offer. And that's where we have also, based on a lot of the studies we conducted based on iSpot, based on these ethical and moral decisions we needed to make as well. And that's why we've shifted to a different way. Many people talk about precision psychiatry, personalized medicine that deals with such questions. And we've moved away to a model that we call stratified psychiatry. And in stratified psychiatry, in depression, for example, we take the whole family of antidepressant treatments. And what we'll do, we'll develop a biomarker that might predict some responsiveness to, say, antidepressant A. And as long as the same biomarker does not predict impaired response to another one, then we have a winner. Because what we can gain with one drug, but if we have to then tell someone you cannot use this drug, however, we stratify you to the other drug that at least is equally effective as the group level response and remission, then we still win, because we take away the drugs, so to say, that people are less responsive to, and then we will never have to make the life or death decision of withholding someone from a treatment. So it's a slightly different perspective, but clinically very important.
Yes. Yeah, no, that is important, and it's worthwhile. Excuse me, it's worthwhile just clicking on that. In that you can, what you're saying now is you're moving towards, well, actually, this is saying that this treatment may not be good for you, or you may not respond well to this treatment. So instead, you should have this one. Now, that's important because A, you can potentially increase the effectiveness, but B, the patient doesn't go on to a drug that is not helpful, that often has very, very significant side effects. And I've interviewed Professor John Reed on my podcast, who's done large studies of real people with antidepressants and found that 60+% of them have a whole host of side effects, including suicidal ideation. So if we can basically go, this drug's not useful for you, or our information is saying, don't take this drug. Whereas if they just gone to the doctor could have said, well, let's try you on this one first. And they go and they have a bad outcome. And then they have to go on to another treatment, but they could potentially be worse off than when they started, right?
Exactly. So rather than a patient coming to a psychiatrist and a psychiatrist having a whole range of first-line choices, have first-line treatments, so psychotherapy and SSRI in 10 different kinds and SNRI in several kinds. And then there's second-line treatments, which is more like RTMS, for example, treatments used for more treatment-resistant patients. So rather than doing a random pick out of one of these, you take a simple biomarker, which most consistently we've shown with EEG, and you pick the one that someone is most likely to respond to. And what we've seen is in replicated studies that we've been publishing out there, and we've seen that you could enhance, based on one or two very simple biomarkers, enhance your remission rates from, say, 40-50% to 60-65%. And so we see about a 30% gain in the remission rate by simply using one biomarker and stratify people between two evidence-based treatments.
That is really significant, right? That 30% uplift.
And that's also what these studies have shown. If we look at iSpot, where people were actually randomized to 3 different drugs, 2 SSRIs, 1 SNRI, and 1 drug with even a slightly different working mechanism. On the group level, remission rates were completely identical for all 3 groups. So the psychiatrist could as well roll the dice and decide on a treatment based on rolling the dice, and we know it doesn't make a difference from many studies.
That's crazy. And can you just let the listeners know? So you mentioned SSRI, selective, serotonin reuptake inhibitors, and selective norepinephrine. Tell our listeners how those drugs are different in terms of their mechanisms of action.
Well, the drugs usually impact on a specific neurotransmitter, and a neurotransmitter is like a small chemical in the brain that facilitates communication between neurons. And some of them are communicating via means of serotonin, other via means of noradrenaline, and we have very often heard about dopamine as well. So some antidepressants have a preference for more dopaminergic neurotransmitters. So we have multiple, maybe tens, close to 100 different antidepressants, and they all have a slight different preference for one or the other neurotransmitter systems. However, on the group level, people are equally responsive to one or the other. And that's really sobering, because in the old days we used to think like, well, maybe we are more dealing with a subgroup of people that have a more serotonergic depression, and other people have a more, say, noradrenergic depression. Well, all the research in that specific area has not indicated any evidence for that. And at this point in time, psychiatrists have no means other than their gut feeling, other than their experience with patients, to prescribe people with a better treatment. But overall still, you could as well randomize people to the treatments, because on the group level, it's not going to make a difference at all. And even, this is within antidepressants, but even if you would add psychotherapy or TMS to it as well, we know TMS relative to antidepressants, TMS relative to each other. There's multiple TMS protocols as well, aiming for right prefrontal or left prefrontal cortex. And on the group level, they have identical results as well. So it's not only true for drugs, but for any antidepressant treatment, we see group level remission rates being quite identical.
And that's got to be really confusing. Excuse me. As well for researchers, when you're looking at different drugs with different mechanisms of actions, and then when you take 1,000 people, same effectiveness. And so that begs the question as to when they are effective, what is the mechanism of action? I've heard some people talk that they think that it's nothing to do with the serotonin and norepinephrine, but it might be that these drugs are increasing BDNF and helping the brain that way. Any comments on that, or have you got any insights into this?
Yeah, I mean, that's the final common pathway of any antidepressant treatment, including electroconvulsive therapy, psychedelics, RTMS. The final common pathway is BDNF, or nerve growth factors expressed in the hippocampus, that supposedly can facilitate neural growth and functioning of specific networks in the brain. So they all have that. So it's not true. Serotonin, it was thought to be a vital part of what was explaining depression, and now we know it's not actually. It's more specific networks and specific parts of the brain where these nerve growth factors play an important role. But I think the honest answer is, how do all these treatments work? I mean, we know there's a final common pathway in BDNF, for example, but still, knowing that some treatments will be very ineffective, they might still have this downstream effect, but maybe they're not strongly enough. I think the first question I would, and that's why I'm an applied neuroscientist, the first question I would like to answer, can we first improve the remission rates by using a stratified psychiatry approach before we start understanding it? Because our understanding will even get way more complicated, where we assumed a whole family of treatments would have the same effect. We're now seeing that within that family of treatments, one drug has a supposedly different working mechanism relative to another drug, even if that's part from the same family. So we're complicating the whole story much more by taking individual variation into account, and that's really where we need to go to.
Right. So you're saying So you're saying now it's like let's do stratification, find a drug that is working better, and then explore the mechanisms rather than, as what happened 20, 30 years ago, propose a serotonin mechanism, make a drug that has an action on it, and then use that drug. So it's a kind of bit of reverse way of doing things, but which I get. I actually get that. But the BDNF story probably at least partly explains why I would imagine you're aware of the British Medical Journal, or BMJ, study comparing a whole different type of exercise interventions to antidepressant therapy, and found that every single form of exercise had a greater effect size than antidepressants. And we know that exercise is very potent at stimulating BDNF, particularly more vigorous exercise. So that would kind of seem to play into BDNF being the ultimate thing that might make a difference.
Yeah, I mean, in that sense, it's not really surprising. One of the most powerful psychological treatments is called behavioral activation.
Yes.
As you imply, any type of activation, especially in depression, could be very powerful, even so strongly. And I recall this from a long time ago. There was a big professor who was specialized in cognitive behavior therapy. And in order to do cognitive behavior therapy, it requires a lot of training, right? And he explained behavioral activation as being so simple that you can even teach a psychiatrist how to do it. And he was a psychiatrist at that time. And so behavioral activation is much simpler to do. And they actually have done head-to-head studies in very large numbers where behavioral activation is non-inferior to CBT. And so it's much simpler to do, and even there, similar to possibly medications, behavioral activation is a very powerful technique to at least get some initial antidepressant benefit. Again, if that's just a BDNF, I think we should also be cautious by just similar to in the past saying, oh, it's a bit of serotonin and slow, we're going to increase it. I think we need to be cautious about it and not oversimplify things. It's probably more complicated. Let's be humble. Let's only start focusing on all the mechanisms once we have identified the various subgroups. And that makes more sense in my view. And anything is simplification beforehand.
Yeah, no, that makes sense. So let's now talk about TMS. So because you have done a lot of work in the TMS space, firstly, explain what it is and how it actually what's its mechanisms of action, and then what sort of conditions is it being used for, and what the hell does heart rate have to do with it?
Interesting question. I'll finish off with the heart rate and keep the most exciting to the end. I think TMS is a very exciting technique, and this was so remember that with brain clinics we're onto doing EEG research, and with EEG we pick up the activity that's projecting perpendicular to your skull. So at that point in time, 2005, 2006, I thought like, well, there's this technique, TMS, which is a very focal, strong magnetic field, and it works in exactly the opposite direction as the EEG that we're picking up. So I very naively thought like, oh, that's interesting. I can see on EEG where something is different, and maybe I can use this technique to then specifically in an individualized way modulate brain activity. And so we bought our first TMS machine in 2006, and we got started. And well, in the end, it turned out to be completely different. So with transcranial magnetic brain stimulation, we generate a magnetic field in the strength of roughly 1.5 to 2 Tesla. That's very strong and very quickly pulsating. And because it's the magnetic or the decay of the field is in the order of nanoseconds, we have a very quick change which can elicit a small current in the brain. And just to illustrate this, if I hold it above my head, my right cortex, so to say, and I'm stimulating the area that's responsible for my left hand, then I can also elicit a movement in my left hand. And so it's really
just with the stimulation. Wow.
Exactly. So it's physical stimulation. There's no, people have done magnet therapies and stuff like that. There's nothing related to that. This is really like physical brain stimulation. So on the other hand, that's also the only outcome we can get. We can stimulate your motor areas and see motor movement, and that's it. So it's always been very surprising to me if I move the stimulation coil to my prefrontal cortex, where my higher order thinking processes take place, that I can stimulate whatever I want, but there's no conscious recollection I get. It's not that I think like, oh, my brain is working different, my cognition is impaired. You really need to do very, very sophisticated behavioral algorithms to get some kind of a readout from the prefrontal cortex. On the other hand, we do know that if you move your coil 5 centimeters anterior in the prefrontal cortex and stimulate for, say, 20 to 30 sessions, we know you get a very strong and robust antidepressant effect in quite a number of people. Again, on a group level, you get remission rates of, say, 40, 50%, which is still meaningful. Also, and this is a very important distinction, taking into account, this is mainly investigated in treatment-resistant people. So people that have failed most other treatments before. And getting such a remission rate in that subgroup of patients, I think is very, very encouraging, because for these people, the only thing left will be electroconvulsive therapy or shock therapy, which is not something you want to be considering too lightly. So ever since
Martin, before you go any further, can I ask why it is used as second line rather than first line, if its effectiveness appears to be as at least effective as some of the first line drugs, and these are on treatment resistant people, that you're getting the same effectiveness? So why isn't it used for first line treatment?
Yeah, very good question. Yeah. This is usually how research goes. For ethical reasons, you're not going to be experimenting in people that are still very likely to respond at an early stage of their depression. And that's why you always start with the toughest cases. But then automatically the insurance mechanism kicks in again. And the insurance mechanism then tells us to only start treating people if they have failed a couple of sessions. Whereas personally, and again, don't take this as official advice, but personally, I would consider that we might make it available much more quickly. And to maybe first-line patients as well. I think in the Netherlands, we have one of the few systems where people could qualify for it quite early on. And we require people to have failed 2 evidence-based treatments, which could be psychotherapy and medication. But if people don't want to take medication, they could even have tried 2 very different types of psychotherapy and then still qualify for RTMS, for example. And this is also based on the evidence out there that will really increase the likelihood of people to respond to TMS. But personally, I do think the future will be going there as well. We will be going to a completely different model rather than popping a pill every day. That's the current model. People will start moving, in my view, more to brain stimulation treatments, short intensive treatment, and then you're off the treatment for a longer period, or maybe with some maintenance treatment. Once every 6 months, people can maintain their remission. And I think similar to psychedelics model is probably going that direction as well, even though the clinical outcomes might not be blowing all the drugs out of the water, but the big advantage of psychedelics is you have a one-time psychedelic experience which can keep you in remission for at least 3 to 6 months, and then you might redo it, which is, I think, at least better than popping a pill every day, which has all kinds of side effects and other mechanisms associated to it.
Yeah, absolutely. And look, I actually know somebody who had treatment-resistant depression and did TMS, and said did 10 sessions and was like, this is doing nothing. Said after the 10th session, boom, complete and utter shift, and was just completely blown away by it. And actually, I interviewed on my podcast a guy who's running the first psychedelic lab in Australia. And they're getting some really interesting results. So they use it with therapy, and his words are that the psychedelics act as a rocket ship for the therapy. But he says if you're going to use a rocket, you need to know how to steer a rocket. That's his big thing, because he says they're so potent. So where is TMS being used? We talked about depression. Is it being used in other psychiatric conditions with any effectiveness at this stage?
Yeah, it's for sure. It's being investigated pretty much in almost any psychiatric disorder, I would say, although the effectiveness varies quite a bit. We know there's very strong evidence for a good use of rTMS in the treatment of depression, in the treatment of obsessive compulsive disorder. Those, I think, are the two main indications. Then when we cross over to neurology, there's some indication in pain, in chronic pain, but the question there is really how sustainable are the effects, because you can get an acute suppression of pain, but if you would need to do TMS every day, it might not be as clinically meaningful there. And that's, I think, still the jury is still out on that one. And other than that, I think there's multiple PTSD is also quite effective as a treatment with rTMS, using quite similar approaches that we use for the treatment of depression as well. The networks seem to overlap to some degree, but I think that's where we have the strongest evidence at this point in time.
Okay, can we shift tack now and talk about what is probably the fastest growing psychiatric condition that's just from what I'm observing and hearing, which is ADHD. There seems to be a bit of an explosion.
I still wanted to touch.
Oh, sorry. Go ahead.
Touch upon a little bit, because I think we've now mainly described TMS, but I just wanted to give this example because I think it's a very nice example also about I think the field of applied neuroscience. Remember that with TMS, we want to stimulate the prefrontal cortex, but the current way of thinking is that TMS is more about stimulating specific networks in the brain, and that by stimulating the prefrontal cortex, the signal will be carried through the whole network to much deeper structures that are inaccessible, like the subgenual anterior cingulate cortex, where also deep brain stimulation is being done. And so in TMS, when we talk about biomarkers and improving treatment response, the most often heard way of doing that is using fMRI. And fMRI scans are very complicated scans where we can look at connectivity from the subgenual to prefrontal cortex. So although this is the most evidence-based at this point in time and most investigated, we've been looking at this for a long time and wanted to achieve a similar kind of outcome, but without using the fMRI, because in my view, for clinical practices, it's not always feasible to have an fMRI scan on premise and have every patient go through an MRI scan. So this is also where you alluded to that, where the heart rate kicks in.
Yes.
And I think it's an interesting topic. So by doing a lot of research and also realizing that there's a lot of overlap between the depression network and what we call the frontal vagal network, or the network that's involved in the brain in regulating heart rate variability, we realized there's a lot of overlap. And what we found actually was that when you apply TMS acutely to your brain, and when you're hitting the right area, that you see an acute heart rate suppression. And that's very opposite to what you would think, because feeling TMS, it's not painful, but it's also not the most pleasant thing to undergo, because your muscle tissue will be stimulated as well. So you would expect heart rate to increase, but not decrease. And so we described it a long time ago. And to cut a long story short, we've done a lot of research now, actually validating it against fMRI-based acquisitions. And we found that the overlap by using heart rate as an acute readout of TMS to identify the right connected areas, it overlapped with fMRI with between 85 and 90%. And so we have now developed an iPhone app where people can use a simple polar heart rate strap together with an iPhone app, do a 5 or 10 minute procedure with TMS, look at the heart rate at the same time, which we call heart-brain coupling. And the app is called Heart-Brain Connect. And we're using that procedure, you can now indeed target the individualized right brain network in an individual, increase likelihood of response, and being as accurate as one could be with MRI. The reason why I wanted to highlight this, because I think this is really the type of innovation that we need in psychiatry to make things scalable as well. And we can have all kinds of advances and over-engineering things as we go, which is happening a lot, to be honest, because over-engineering, making more sophisticated stuff will earn companies more money. But we also have to think in the opposite direction, like disrupting the field of brain stimulation and making it way more accessible. I would like to see that every first-line psychology practice would have access at some point in time over a very simple stimulator, maybe only doing 1 hertz, and have a very simple targeting techniques like using heart rate to improve the clinical outcomes to a large degree already, and therefore making it way more accessible to people. And I think that's why I wanted to highlight this as an example of how very sophisticated fMRI-based neuroimaging can also be engineered, if you will, to a very versatile clinically based utility using heart rate outcomes.
And the cost of a heart rate monitor and an app versus an fMRI machine is a little bit different, isn't it? And so is this process mediated through the vagus nerve?
Exactly.
Because often depressed people have got very suppressed heart rate variability. Can you just dive into this a little bit more, that connection between the heart rate variability in the brain, and exactly how are you using heart rate to inform the TMS or guide the TMS? This is fascinating. So just ridiculously fascinating.
Yes, so when you span the whole network, ranging from the prefrontal cortex that's accessible, you then do a deep dive, so it's between your eyes, and then you go a couple of centimeters to the back of the head. That's where the subgenual anterior cingulate is located. The subgenual anterior cingulate is involved in the treatment of depression because if people do deep brain stimulation, they lower some electrodes into that area. And start stimulating that pretty much permanently in order to resolve your depression, which is very effective. And then when we go to the back of the head, basically to the brainstem, there we have the vagal nerve that will exit the brain and will be going to your heart, but also to the gut. So it's the heart-brain-gut axis, basically.
Yeah.
And we also know that when we take this vagal nerve and we encapsulate it by an electrode and we start stimulating that, called vagal nerve stimulation, that can also be a very powerful antidepressant treatment. So we know that these 3 nodes, ranging from the cortex to subcortical areas to the brainstem, that's a whole network that's being aligned, that's functional, has some functionality in the pathophysiology of depression, and indeed therefore mediates heart rate variability, lower heart rate variability levels, but also there's a big crosstalk between cardiovascular disease and depression. People that experience cardiovascular accidents are more likely to develop a depression, and people with depression are more likely to develop cardiovascular accidents. So there's a lot of overlap between those 2 networks, and that's basically the network that we utilize. So imagine that the TMS, we always thought that with TMS we're only stimulating local focal areas. Not true. We're stimulating a prefrontal area, and the stimulation pattern that we apply on your prefrontal cortex is a pattern that your vagal nerve is responding to with an identical stimulation pattern that we can read out on your heart rate. So we can even tell by using one protocol or the other. I can tell by looking at your heart rate only, I can tell which protocol you're stimulated with if you hit the right area. And we've tested this because many colleagues shared data with us, heart rate data, and we did not know whom we were dealing with. But by simply looking at the heart rate, we could unblind clinical trials with a 90% accuracy. And so we could simply tell, like, this is real stim, this is fake stim, but by just looking at heart rate. So that's how profound these effects are as well. We're not looking at a small correlation. We're looking about something that you can individually apply and tell on an individual level as well.
Is there, I mean, that is just unbelievable. Is there anybody looking at, or is there any intention to then look at whether the gut microbiome is being affected as well? Because the vagus nerve stimulates the gut, and I know it has an impact on the gut microbiome. I mean, anybody who has had irritable bowel syndrome from stress knows that body-brain connection, and we know that eating a shit diet and changing your microbiome can influence your brain function and drive depression as well. So is there anybody looking at that, or is there any plans to look at whether the gut microbiome is playing a role?
Well, very spot on. I mean, two aspects there. I think looking at the heart-brain-gut axis. Some of our colleagues at Bern University in Switzerland are currently running a study where they look at that, where they look at TMS applied to the cortex, look at heart rate changes, but also looking at the electrogastrogram. which is like the
Right.
measuring the very slow electrical activity of the gut. So that's one group. That's the first kind of research to see if that type of top-down stimulation is also arriving in the gut as a first step. But I think also a second step is that there's a lot of overlap between the vagal system and vagal integrity. On one hand, in immune function. And we know
Yes.
inflammatory markers are also highly elevated in subgroups of depressed patients. And together with another group in Germany, they are also looking at using heart-brain coupling to tease out how that relates to possible anti-inflammatory effects or inflammation in general. And so yes, for sure, this technique is getting more widely available. It's very easy to do, obviously, but there's multiple people currently diving into this much deeper.
And Martin, so just to clarify for our listeners who may have missed that, the immune system, the reason why this is important is that about 80% of your immune system resides in the gut. Because basically that barrier between the mucosal barrier is the last barrier between the outside world and the inside world, essentially. And is a very easy way for pathogens to get into our system. Hence, if people have an irritable bowel, they can develop, or they have leaky gut, they can develop all sorts of autoimmune disorders. So not only so these magnets then are applied to the head, stimulating brain tissue and pathways that then activate the nervous system, have an impact on the heart, also then can impact on the gut and potentially modulate the immune system just from placing magnets on the head. Who would have known that 50 years ago? It's crazy, eh?
Exactly, but this is also very, very new information. And also, I think it testifies to the fact that brain stimulation, where we thought it was very focal, had only one effect, we now see there's a multitude of potential mechanisms that might impact and therefore treat various subgroups of people as well, and maybe people with an inflammatory subtype or people with a brain connectivity issue and that's why I stated before, trying to already jump the gun and start thinking about a working mechanism or what is affecting, what is a final common pathway like BDNF, in my view, is jumping the gun. We first need to understand the subgroups much better before we can really talk about a final common pathway or a working mechanism, etc. Because here again, we had one treatment where we thought we only had one effect, but we've also already isolated here a couple of potential mechanisms in how depressive symptoms could be mediated, whether anti-inflammatory, whether from brain connectivity, etc.
Wow, that's just astounding. Let's now jump and talk to ADHD. I have often said to people that if your diet is shit and you don't sleep well and you don't exercise well, you will probably fail an ADHD exam. What's your view on the lifestyle factors playing into ADHD? And this explosion that we are seeing in ADHD diagnosis, and look, I'm not going to ask you to put a figure on it, but is at least some of that mediated by poor lifestyle?
Yeah, very good question. Well, lifestyle for sure, although I cannot cover all aspects of lifestyle, I think there's one important one. I was trained in sleep medicine for a while as well during my studies. And I've always found sleep very fascinating. We spend about 30% of our whole life in this state called sleep, so that must have repercussions in our daily function. And
Yes.
especially, I think, in psychiatry, where unfortunately psychiatry and sleep medicine are two completely isolated fields, and they don't really talk to one another. Whereas in my field, in my view, it's very important because in all the symptom checklist for depression and for ADHD, there is questions relating to sleep, asking about it, but not acknowledging it could be an etiological factor in causing such symptoms. In depression, the most powerful treatment we have is sleep deprivation treatment. You keep someone up all night, the depression is gone next morning,
That's
Unfortunately,
right. Yes.
unfortunately, when they fall asleep again, their depression pops back up. There's a way to mitigate it, but that's a whole different discussion. So sleep plays a very, very crucial role in my view in psychiatry. So with ADHD, we stumbled on this quite accidentally. We have been involved in a field called neurofeedback for quite a long while. I will not dwell on that too long. There's a lot of pros and cons about that field. I know myself as well. But one of the things we observed at that time was that when we did a specific protocol called sensory motor rhythm neurofeedback, which can also be used in sleep, people with sleep problems, that's the most frequently reported side effect people reported was improving sleep. And we were treating a lot of people with ADHD. And after a while, we started using actigraphy, similar to Apple Watches and all the devices we have to quantify sleep these days. And we started actually putting a magnifying glass on it and saying, like, well, what's happening with sleep? And when we started doing it, we found that many people with ADHD actually were presenting with what we call sleep onset insomnia, having difficulty falling asleep or falling asleep at a time way too late for someone's age group bedtime, so to say, but also disrupted sleep and very short sleep in the second half of the night. Well, to cut a long story short, there's actually quite a lot of research available right now. Also out of Australia, there's some groups looking at it. But I think what we now know is that when you look at the population of ADHD, about 70 to 80%, 80, of people with ADHD suffer from something called sleep onset insomnia, which means that they take longer to fall asleep. And we also know that's pretty much related to melatonin, because melatonin is a sleep hormone that starts slowly to be released in your brain to make you fall asleep, more likely to fall asleep. And that rhythm is often delayed in ADHD. So not only do we have the behavioral symptom of difficulty falling asleep, we also know that the sleep hormone is significantly delayed for a couple of hours in people with ADHD. So what we're seeing is that many people with ADHD, basically, especially if we focus on children, school times are the same for everyone. But if you fall asleep 2 hours later, you are chronically missing out on 2 hours of sleep per night. So how can we link that to behavior? Well, that's very simple. A lot of research has been done in the United States, for example, with a very simple question. If we send our people out to a war zone, can they do well with less sleep? And so they've done a lot of sleep restriction studies, chronically sleep restricting completely healthy people and measuring the consequences. Well, the very simple answer is no, they cannot do with less sleep. So they've taken healthy people, and if you measure something called the PVT lapses, which is like a neuropsych test, you then observe how often they have a lapse of attention. Then people were submitted to sleeping 8 hours for 2 weeks, 6 hours, or 4 hours. And there was also a group of people that were not allowed to sleep at all for 2 nights, because you can't extend that much longer. So after 2 weeks of sleep restricting people to, let's take the 6-hour example, and I think many people listening to your show will say, like, well, that's me. Some people are proud of it. Personally, I would not be too proud of it. And basically after 2 weeks, their concentration would be as bad after 2 weeks as the people that did not sleep at all for 2 nights. With the very big difference, if you ask them, like, how are you performing? How are you functioning? They would say, I'm doing fine. So sleep restriction is really a silent killer, because without you being aware of it, without you knowing it, your cognitive performance, your working memory, your concentration will significantly deteriorate after 2 weeks to a level quite similar to someone being sleep deprived for 2 nights. You are not aware of it, and also recovering from sleep debt. And you can go to a bank and borrow money. Well, your body is even worse than a bank. If you build up a sleep debt, you need to pay back your sleep debt. If you don't pay it back in time, you'll be suffering in terms of cognition, etc. So this sleep debt that has been gradually building up over 2 weeks, you need to pay it off, and it takes often the same amount of time before you have paid back the sleep debt. So it's not true that sleeping in on a weekend for 1 or 2 nights, which really is not like the same quality of sleep that you've been lacking of, but that's not enough. You need to have a consistent amount of sleep, which is really between 7 to 9 hours for the majority of people. So with this model, we now understand that if people are missing out on 1 or 2 hours of sleep every night, their concentration in school will be disadvantaged, will be at a lower level. We also understand that if you and I would have that night of bad sleep for multiple times, we're driving a car, we know the likelihood of an accident is increased. So what do? We take a Red Bull. So what are we doing with the kids? We're prescribing psychostimulant medication like methylphenidate, which we know will improve their neuropsych function at that time, but it's not a cure for their symptoms. The cure you will need to seek into the sleep promoting effects and sleep enhancement effects. And this is really, I think, complementing the whole circle in how we understand how one lifestyle factor, imagine if we focus on all the other ones, but things like sleep can explain the behavior. And also the hyperactivity is very easily explained as well, because people, you probably have observed small children, and when they're approaching their bedtime, they're running around like crazy, which is a compensatory behavior to keep yourself awake. And so it's an autoregulatory behavior. And therefore, the whole symptom domain of ADHD can be, for a majority of people, not for everyone, but for many people, can be explained by not getting enough sleep. So remember then, a small rewind, we came from the biological clock, this melatonin transcription being coming up too late. So how can we understand that? Well, there's many environmental influences these days, like blue lights, iPads, big screens very close to your eyes that are emitting a lot of blue light. And we know that this blue light can acutely suppress your melatonin. On the other hand, the biggest source of blue light is sunlight. And when you have a jet lag, the best way to beat your jet lag is get out and get enough sunlight so you resynchronize again. So we know that there's like a balance between blue light exposure in the evening on the one hand, but especially getting enough sunlight in the morning. That will resync your brain. So we've published one study, and I think there might be a couple of graphs online about it, where we've looked at the prevalence rate of ADHD in the United States and the amount of sunlight you get throughout the US. So basically a map, where do I need to put my solar panels? So we married these two maps, and we could find that the amount of sunlight in California, for example, relative to New York, would explain 25% of the prevalence rates in ADHD. So this is way more than the current genetic influences we have found. And we've replicated this now about 3 to 4 times. And it still holds for mainland Europe and the US. It does not hold for Nordic countries like Scandinavia. That's a whole different story. Probably that has to do with genetic differences in people being more protected against low levels of sunlight because they're close to the North Pole.
They're adapted in some way.
Yeah. So again, the conclusion should not be take away all these iPads, etc. Prohibition is something that I'm not a big fan of as a Dutchman, but get people out in the sunlight. Yeah? If you have your child and you have a dog, well, ask your child to walk the dog in the morning. And you know the story about where often they would say in classrooms like, well, that hyperactive kid, don't put it close to the window because he will get distracted. Now we need to invert it and say, well, yes, put that kid near to the window because they will get more sunlight catching their eye, and they will normalize. They're more likely to normalize their sleep in the morning. So early morning sunlight, I think, is a very important thing. It's not going to cost a thing. It doesn't have any side effects. It's not going to work for everyone, but it might at least have some improvements. And if at least 20 to 40% of the people will sink below the clinical threshold and not have a diagnosis of ADHD, then I think we've won a lot already. And also, I'm not advocating against medication. It's the most powerful psychiatric treatment we have available. But I do think that for many people, we need to zoom in more on sleep. Psychiatrists need to do their work better and ask more questions about sleep. maybe include wearables, use some sleep-related questionnaires to see if there's an other explanation they can find for the symptoms, which is, according to the DSM, they need to ask those questions, but most people are simply too unfamiliar with sleep medicine to do it in an objective fashion.
That is unbelievable that it explains 25%. And to your point, you're not saying we shouldn't be medicating, but if a chunk of these people don't actually need to be on the medication, if we can prevent them going into that, that is clearly the way ahead. And you know, I'm sure nobody's done the study yet, but I would be willing to bet my house, my business, and pawn my children on the idea that if you also improve people's diet and getting them exercising, especially outdoors, we would see a significant drop in those symptoms, particularly when we see some of the data coming out that American and Australian kids are spending 90% of their time indoors, right? And you know, we have these circadian rhythms for a reason. And most people don't realize, Martin, that lots of your hormones run off circadian biology as well. So it's not just the sleep, it's the widespread effect throughout that biological system that is the human being that is hugely important. So this has been absolutely fascinating. I could talk for hours about this, but before I do let you go, I know you're involved in a number of spin-off ventures where you're actually taking this research technology and applying it. Tell me about some of the stuff that you're doing that you're finding quite exciting now for the future.
Well, currently we've had a couple of spin-offs, like for example the whole clinic where we pioneered the TMS since 2006 was spun out as Neurocare Group. I think they also have clinics in Melbourne, Sydney, across Europe and across the US as well, which I think was quite exciting. Recently, we also spun out the EEG prognostics department to Schneider, where we do the stratification to treatments using EEG actually. So that also has basically, given me a lot of time and to think about new things. So I'm currently, see where the new science is going to bring me. So I'm doing a sabbatical currently at Stanford University. On the one hand, wanting to learn more about psychedelics, which I think is a really fascinating field. And on the other hand, still pushing the research at Brain Clinics Foundation in collaboration with many partners on the heart-brain coupling. I think this heart-brain coupling to inform TMS is a very fascinating field. So that's mostly the stuff that we're trying to focus on at this point in time.
That is some very cool stuff right there. I tell you what, when I was a kid, I always admired explorers, and there's not much exploration left to do in terms of geographical exploration. But oh my God, are you in an area where there's a lot of exploration to be done, and you're doing some very, very cool stuff. So Martin, I tip my hat to you, sir, and I love everything that you've talked about here, the stuff that you're doing. It is super exciting, and hopefully that time in your sabbatical spikes some new neuronal connections, and you'll be off onto your next venture.
Yeah, looking forward to that.
And where can people find out more about you if they want to just look at your work? Where's the best place to send them?
Yeah, the best place to look at is our website, which is brainclinics.com. So brain clinics plural. Also on LinkedIn, you can find my profile and connect me via LinkedIn or reach out via email, whatever people prefer. And for those people that have an interest in TMS, we have an upcoming TMS masterclass in the end of September, beginning of October, where we invited some of the world-leading experts with very new insights on TMS. Some people are doing TMS in one day rather than spreading out across multiple days. Many new innovations will be shared there. So for those interested to do a real deep dive, we have this masterclass coming up.
Excellent. Martin, thank you for your time. This has been awesome.